SIBO breath testing is a main diagnostic tool, but the results are far from simple to understand. What if the most common version, the lactulose test, is prone to false positives due to normal anatomy? Even before the test, simple dietary mistakes can completely invalidate the results you receive. And it's not just food. Common medications and supplements can seriously skew the final outcome. This report details the steps for accurate interpretation, from patient prep to the nuances of all three gases. Getting this right matters. SIBO symptoms, bloating, pain, altered habits, massively overlap with IBS. Without a reliable test, it's a guess. The supposed gold standard culture is invasive, costly, and often misses key bacteria, making breath testing a practical clinical tool. So if we are relying on these tests, what are we measuring? It comes down to two gases produced by microbes, hydrogen and methane. For hydrogen-dominant SIBO, a rise of 20 parts per million over baseline in the first 90 minutes is the North American standard for positive. Methane is judged differently. A level of 10 parts per million at any single point during the test is considered a positive finding. But before that rise, look at the baseline. An elevated start can be a red flag for poor prep or oral bacteria, not necessarily SIBO. Why are the rules for these gases so different? Because they don't exist in a vacuum. In the gut, hydrogen isn't just waste, it's a currency. Hydrogen-producing bacteria create the very fuel that methanogens, the methane producers, consume to live. One organism's waste is another's food. This is why we now use the term intestinal methanogen overgrowth, or IMO. These are archaea, not bacteria, and can live anywhere in the GI tract. But methanogens are not the only microbes that consume hydrogen. So what does it mean if a symptomatic patient produces almost no gas at all? This biological reality is why medical consensus is so hard to achieve. Different research bodies have slightly different rules for interpretation. Understanding this science is key. Now, how does it apply to the tests we order? The first choice is the substrate, glucose or lactulose. Glucose is absorbed early, so it's highly specific for SIBO in the upper part of the small intestine. But its primary weakness is significant. It can completely miss bacterial overgrowth located further down. Lactulose travels the whole way, but fast transit can cause a false positive by showing a colonic response too early. Test duration is another factor. For patients with slow transit, a standard 2-hour test may end too soon, requiring a 3-hour test instead. With these pros and cons, reading tricky results is a skill. So, what about the tests that don't fit the classic positive patterns? Remember the question about the flatline test? This is where the third gas appears, hydrogen sulfide. Its producers also consume hydrogen. H2SSIBO is often linked to diarrhea and a rotten egg odor. It's frequently missed by two gas tests, needing clinical suspicion to diagnose. This is why a sophisticated reading looks past one number. You must analyze the entire gas curve. Double peaks and late rises tell a functional story. The timing of the peak is telling. An early rise points to upper small bowel overgrowth. A later rise may mean distal overgrowth or normal function. We've covered prep, baselines, test choices, and the three gases. How do we pull these threads together to make a confident diagnosis? Let's connect the dots. A patient eats fiber before their lactulose test. This causes an early hydrogen spike that looks exactly like a SIBO diagnosis. Or consider gas interactions. We know methanogens consume hydrogen. Treating only the hydrogen producers may not resolve methane-dominant constipation. A patient with high methane or suspected H2S might show low hydrogen. The hydrogen producers are there. Their output is just being consumed. Multiple substrates, conflicting guidelines, 3 potential gases, and vital prep factors all prove the central point. SIBO diagnosis requires a systematic approach. Reading a SIBO breath test is not a simple positive or negative question. It is a systematic evaluation of your body's data. Always verify prep and baseline. Choose the right substrate. Look for all 3 gases, especially when one is flat, and analyze the entire curve. This is why a new systematic interpretation framework is a vital step forward, giving clinicians the structure needed to navigate these results. For practitioners, use these principles to sharpen your skills. For patients, use this knowledge to have a more informed talk with your provider.